All of the clinical trials. You don't have to read any of those names. They all have to do with immunomodulatory, trophic, or antibacterial capabilities. So I'm going to talk about one other company, which is one of the reasons why I came to Japan, is to introduce the Japanese to a company called Lipigens, and the inventor, Carlo Tremolata, is sitting here in the front row. Raise your hand, Carlo. This is Carlo. This is Carlo under various different conditions. He's a plastic surgeon. He's showing people how to use this apparatus that I'll show you in the next slide. And this is with Konrad Slanarski, a very talented orthopedic surgeon in Poland, where they've set up a clinical trial for osteoarthritis using this apparatus. So the apparatus is very simple. It's a plastic tube with saline in it. You take liposuction material and you put it through this side of the tube. This side has wires which further disperse the lipoaspirate, and then you shake it like a martini. So you can be either sexy about it or boring, however you want. And what the stainless steel balls do is they rip the MSCs mechanically off the blood vessels that are broken up, and then you put some more saline into the solution, and all the broken cells and all of the oil and all of the debris gets washed out. And the genius of this, I hate to say Tremolata is a genius, but for a plastic surgeon to do real engineering, he's a pretty smart guy. So there's 500 micron holes on the back end. So all of the small pieces get washed out, and what gets trapped at that back end is a ball of live adipocytes. And inside this ball are MSCs. And so it's a slow release vehicle for MSCs, particularly for joints or soft tissues. So for ACL reconstruction, for osteoarthritic knees, for rotator cuff damage, for all of these tissues, you can inject lipogems in, the acute inflammatory response goes by, and the MSCs 5 to 8 days later come walking out to do their magic in that tissue. So you don't need millions per kilogram. You need a few MSCs in the right place at the right time to do the management of what the tissue can do by itself, including regenerating cartilage, including regenerating meniscus that's been previously cut off. These tissues inside a knee.
What's the size?
Pardon?
What's the size of a particle?
Particles, the balls are pushed through a 500 micron hole, so they're about 500 micron particles of live adipocytes and MSCs inside. So again, this is approved in Japan as a fat transfer technique. This is approved in the United States in a 510K as a fat transfer technique. This is not a stem cell isolating technique. This is how Mother Nature packages some of its medicine. And I think that's the important aspect. And now this is going to start to be introduced in Japan and go through the regenerative medicine logic. And I hope it gets classified as class 3, because this is like any surgeon would do fat transfer, the same, or take fascia and use it in an abdominal reconstruction. This is the practice of medicine. Nothing's changed. Everything is the same as Mother Nature has it. And so I would say, actually, what we have done in the United States, we try to be a little bit ahead of Japan. And so we have now legislation next week will be introduced where we change from homologous use to clinically homologous use. So you could take this and put it in the shoulder or the knee or do it for breast reconstruction. It's clinically homologous use of MSCs in this regard. So again, these cells are drugstores. These MSCs are drugstores for sites of damage, and they are site-regulated multi-drug delivery vehicles. Again, injury, perisite comes off, becomes an activated MSC. The MSC on the front makes a curtain of immunomodulatory molecules, and from the back, trophic molecules, which are anti-scarring, angiogenic, and mitotic for tissue-specific stem cells. That's the key. This is not a stem cell. This is a drugstore for sites of injury. We know the chemistry of what controls the binding of pericytes to the basement membrane of these blood vessels, and it's a boring molecule called PDGFBB, actually anchors the pericyte to the basement membrane. And so if you use PRP in a clinical context, all you're adding is PDGFBB, and it activates the MSCs and brings it off the blood vessels. So again, the key aspect of these cells are their medicinal properties. So this is the original hypothesis diagram. The diagram's wrong, because I never asked the question, where does the MSC come from? MSC comes from pericytes. So that changes the way you think about it. And MSCs are not from stroma. They're not stromal cells. Stroma is connective tissue. MSCs come from pericytes. It just changes the way you think about these cells, and when you're trying to reconstruct a multi-layered tissue with vasculature, you need to put the pericytes in, because that's what's going to control the blood pressure, the eventual blood pressure through that new tissue. So remember, MSC now stands for medicinal signaling cell, okay? It's not a stem cell. That's an important point. So this is a poster which will be first distributed at the ISSCR meetings at the beginning of the year. And I'm only going to pick out one small part from this poster to tell you that every tissue-specific stem cell has the same niche. So this stem cell is sitting on a vascular endothelial cell, and next to it is a tissue-specific pericyte MSC. This is the same for the hemopoietic stem cell, the neural stem cell, the hepatic stem cell, the muscle stem cell, you name the stem cell, cardiac stem cell, they're all dependent on the MSC pericyte that's sitting next to it. This is a completely new concept.